Dr. Singh has worked for the last 25 years with the Inuit and the Cree in northern Quebec, which warms my French-Canadian heart. He's trained both in family and emergency medicine and has spent a large part of his career working on how we think about resuscitation in austere environments. One of his quotes that is in a lot of his bios is, "Any resuscitation, anywhere, anytime." To accomplish this, he sort of thought a lot more about sport as opposed to some of his medical training, which I think he's going to talk a lot about with us today.
So the big yellow circle is where I've been working for the last 25 years primarily, all up and down the coast. And it says 15 plus 11 years, which makes 26. For the first 5 years, it was brutal. I was not prepared in my training for what I was seeing up there. And I had to get better or get out. So I spent about 10 years. I didn't know it at the time, but I was essentially doing a residency on how to do resus up there. And then I figured out I had a better way to do this. So I thought I got to test myself. I want to see if this really works. So I went back to do emergency medicine. And they called me and they're like, why are you doing this? Just write the exam. I was like, I actually don't care about the exam. I want to see if this works because I want to change the system. And the problem is if you call them up and say, hey, I'm a HIC doctor up in POV and I think you need to change the way you teach ATLS, that's the reaction you get. So one of the reasons I went back was to be able to say, hey, I can, like Jonathan, work in a tertiary care center, be a TTL, and I can work in the back of a helicopter. And there are better ways to do this. And like many of us here, outside of medicine is where I found a lot of the answers to these questions. So a couple of questions that were posed for this talk. How can small teams have a big impact, and how can small teams find time to sim? I think small teams can have a big impact, but there's a really important thing that needs to be done. You need to have the desire, and it requires big design. It's not an accident. This is a diagram from Sports Canada. And in medicine, I'd say we have generally a culture of quality. It veers into harassment sometimes, or not infrequently, and sometimes inclusion. But I would not say we necessarily have a culture of excellence, and that's a different kind of thing. And excellence requires a different mindset and a really structured approach. And often when you talk to special operations people, they tell you we're getting 1% better every day. And that might be possible when everyone on your team has the same mindset, but when they don't, it's not going to happen. So I was content with getting 0.01% better every day, but the days add up. You need to have passion, you need to have allies, and you may be alone, like our dancer yesterday who started off dancing. And so this is where you need to be a bit strategic, and you may need to align people's needs with a vision. So, hey, would you like to feel less stressed when you're doing a resus? Yeah, I'd like to be less stressed. Let's work on that, and also we can improve a patient outcome at the same time. Motivation is a big thing, and remuneration comes into it. We've had trouble over the last many years getting our staff to engage in simulation, and we finally succeeded by having paid sim time. It's part of the day. It's part of the day. So trust and safety is critical, and the things you're trying to develop are agility, expertise, and focus. And there's a couple of principles that I abide by. I think humans are more important than any hardware. You have to invest in people, and you have to have good people. And I really prioritize quality over quantity, and conscious, consistent effort. And I call it a relentless pursuit of excellence. And this has been a struggle for me in medicine, because medicine has a toxic relationship with failure. And often when you start asking deeper questions, people think you're trying to blame. And this is our fault. We've all been to M&M rounds where morbidity and mortality, or something comes up and you see someone get chewed out and they make you feel like crap. And this is a problem. And excellence is not about blame, it's about getting better. And you have to ask some questions to do that. And that's sort of a challenge that I face. I was sending emails last week on this topic. So one of the big things is that context is critical to what we're doing, and it's acknowledged. Oh yeah, you work up in the middle of nowhere. That's a different context, but it's not actually fundamentally understood, and this leads to fundamental failures in the application of what we do. So I'm going to kind of flesh out a bit of a story. The question is, how can small teams find time to simulate? And I'm going to give you kind of an exaggerated answer, but I don't think they should. I don't think you should simulate at all in the way we presently do it. And I think you should be doing deliberately designed training, which is very different. The typical sim session is going to be an 8 to 10 minute simulation. We'll debrief for about 4 minutes, and then we'll repeat a case. And it ends up being kind of a sim, rinse, and repeat session. And the problem with that is your expertise is developed an inch deep and a mile wide. And when this little kiddo comes in, I can guarantee you that an inch deep is not going to cut it, because things are going to go wrong and you're going to struggle. And that's when you're going to question yourself, feel like crap afterwards. You get the PTSD, the moral injury, and the burnout. Okay, so what you really need is a level of mastery, wide and deep. And this requires exploring failure. And we're not really very good at exploring failure. It's not part of the skill set. It's not something we're taught to do. And when you leave medicine, they spend a lot of time doing it. So I don't know if you guys know Ronaldo. He's a very famous soccer player. And if you go watch any professional sports team play, they don't just play a game over and over and over. They have a very different methodology of practicing. So you can see him doing stuff. He's literally practicing how to walk still. And he's one of the best players in the world. And when he's practicing how to walk, it's influenced by all the other skills he's developed. And we don't practice the basics enough. So in sport, we have this concept. It's called junk training. It's context deficient. And I teach ATLS, ACLS, PALS, and ITLS. And one of the reasons I became an instructor was to be able to say that these courses, while they're excellent, are very limited in their capacity to actually outfit you to be able to function outside of a tertiary care center. And if you don't believe me, believe the 3-year-old. So we waste a lot of time. I can't tell you how many thousands of dollars I spent doing these courses over the years, and the return on investment actually is pretty minimal. And it's not just me. I see my colleagues suffering all the time. So at some point, the question is, do you want to simulate or do you actually want to get better? And this is where we need to focus really on process. Process is the most important thing. And endpoint is something that we want to consider. But if you have a good endpoint, but your process was flawed, then you just got lucky. So I'm going to give you a couple of examples. We had a case a couple of months ago. Someone got shot with a .22, so small caliber, came into the clinic and had a positive FAST. So a FAST is an ultrasound, and you can see there's a few pink spots there in the middle image. So there's blood. So this person's bleeding. Where we were working, we're about a 45-minute drive to the hospital to get blood. And so the decision was made to intubate this person and then ship them off to the hospital. And so we were on trauma rounds, and the trauma surgeon was like, just wanted to pop in and say, that was excellent that you guys intubated him. And then I piped up and said, well, I wasn't there. And if this guy was actually agitated and hostile, you're getting intubated because we can't risk the team on a transport. But if he wasn't that agitated or hostile, I might not have intubated him. In fact, I would not have intubated him. I would have done everything in my power not to intubate him. I would have taken some Haldol ketamine, a Cric kit, and maybe an LMA and gone. And I'll explain why. F1 pit stop, a good team these days takes about 2.1 seconds to do a pit stop. Okay, and on the column on the left, you'll see a full crew of 15. They go through those 4 steps to get that pit stop done. Now, if you cut that crew down to 4 people, the task flow is now changed. You don't have 3 people per wheel. You have 3 people on one wheel who then have to move to the next wheel, and then move to the next wheel, and move to the next wheel. So just that adds time. You're now having to pick up tools up and down, up and down, up and down. So the chance of you dropping them or screwing it up is higher. And so everything is done in serial now. Nothing is done in parallel. And every time you switch tasks, there's a cost to that. It takes you a bit of time to get back into it. So if you take a look at the red row, a pit stop of 2.1 seconds, if the team is cut down to 4 people, it's going to take them about 15 seconds to do it if they're really, really good. And if they're not experienced, it may take them 30 to 60 seconds to do it. Now, in intubation, Carolyn, you're here. Intubation, 4 minutes-ish, like nothing complicated. I did an intubation one time up north and it took 50 minutes. And I was like, I just did one last week at the MGH. It was 5 minutes. Like, what happened? And I thought, it was just a group of nurses weren't super experienced. It was a one-off. And then it happened again 2 weeks later. I was like, okay, something else is going on here. Like, this is not adding up. And to get a 4-minute intubation, a lot of stuff is preloaded. The pumps are the same. The meds are the same. The Pyxis is there. Like, everything is ready to go. And if you have an experienced small team, you might get intubation done in 35 minutes. But an inexperienced team, and you can see the multipliers I've done there, 7 times and 15 times. So 70 to 140 minutes. So take a guess how long it took that team to intubate the gentleman who was shot. Just wild guess. Give me a number. 47. Close. Yeah, 110 minutes. Because the ventilator messed up, there was alarms, they couldn't troubleshoot them, the pumps defaulted to minimal flow, no one knows except for the doctor. Like, it was the typical stuff that happens. Who here is not a healthcare worker? Raise your hand. You're shot. Would you rather have blood in 50 minutes or 150 minutes? Everyone heard that? So these are non-clinicians telling you, hey, I'd rather have blood in 50 minutes. The intubation took about 100 minutes and the drive is 45. And if I just say, hey, we're going to go, I'm going to grab a couple of things and we're on the road, it's 50 minutes. And we'll tube you there, and in the worst case, we'll crank you in the ambulance. And so I realized something. I'd had this notion that trauma surgeons know everything, right? Especially the ones who've been to war. And then I heard a talk by an emerge doc who ran the Kandahar hospital. And it was literally built of plywood, linoleum, and a lot of duct tape, because they had duct tape to patch it together. And every time shrapnel came through the walls, they patched the holes with the duct tape. So it literally was duct tape. They had 2 CT scanners, ultrasound, blood, endoscopy, anesthesia, general surge, orthopedics, neurosurge, maxfiche, radial. So they had everything. And I realized they might have been in Kandahar, but this was essentially Sunnybrook in a tent. And when the trauma surgeon says, oh, it's good you intubated, he actually has no clue that it takes 100 minutes to intubate somebody. He's just like, yeah, intubate them and go. Because if you tell him it's going to take 100 minutes, we got blood 40 minutes away. Different story. And so this is a big problem in that a lot of the teaching we do is done by people who don't understand the context. Now, that context had very specific things. They learned a lot during Kandahar. They learned that you should not put a trauma surgeon as a TTL because they disappear into the OR and then things fall apart. So all the trauma team leaders became the emerge docs. They learned that, yeah, we have 2 CT scanners, but when we get 10 guys with head injuries, that's a problem. So they trained the general surgeons to do burr holes right away because they couldn't wait for the CT scan. So their context determined some stuff, but there's a lot of stuff that didn't get determined. So when you're working rural and remote, your cup is overflowing to an extent that people don't understand. We had trauma rounds again. The surgeons don't like me at trauma rounds. And someone had trouble with the chest tube. So they're like, well, this is no problem. We can organize chest tube practice. And I was like, no, you should not organize chest tube practice. You got to look at the whole scope of things. And we get pediatrics, obstetrics, preterm labor, preeclampsia, NRP, orthopedics, all the stuff that we got to do. And honestly, we get preterm labor more than we get chest tubes. And preterm labor is very complicated. You have to do fetal fibronectin, maybe tocalize, check the baby. If the baby's coming, you got to resuscitate the baby. You got to give magnesium for neuroprotection, steroids for pulmonary protection, organize it. Like it's a nightmare. But you could save 2 lives if you do it well. And what you need to understand is you need to reevaluate how everything is done when you're in an austere environment. So people would always tell me, Kavi, you just got to keep things simple. And it was really frustrating because I was like, well, like, what does that mean? Like, how do you do that? Like, what is that? And so it took me about 10 years to figure this out, but there's an actual process you can use to simplify things. And you start by cutting out anything that is unnecessary. And you have to have some expertise to do this. You don't just ask your 3-year-old, hey, what should we cut? And then you have to really spend a lot of time in human factors mating what you've done to your workflow. And then you have to strategically chunk it to make it easy to remember and use visuals wherever you can. And you need your toolbox to look like the bottom one, not the top one. The bottom toolbox, I can grab the tools without even looking and use them with my eyes closed. Because I think you need to be better at resuscitation up north in a remote place than anywhere else. So I said to them, there's never an emergency to put in a chest tube. There's literally not. There is an emergency for a tension pneumothorax to make a hole. So you should be training people to recognize, hey, I think there's a tension pneumothorax, make a hole. Then we will maintain that hole with something. And here, my wife, we had a trauma. My wife recognized, she's like, I think we need to make a hole. I said, yeah, we do. She made the hole. And then we put an endotracheal tube in just to maintain the hole for a few minutes until we got a chest tube in. But just that logic helps decompress things a lot. And we're part of the problem. There's a lot of research coming out. This is resus optimization over the last 10 years, 5,000 results. So if you actually screened all those papers, it'd be about 10 a week. And that's just to screen them. And so it doesn't make sense. So I had a colleague who listened to an MCRIT episode, simulations of nurse-led ACLS. So this is actually a really common thing. It works quite well. And he was really bummed out because it failed. And he was really surprised. And I was like, wow, I knew, like, as soon as you said that, I knew it was going to fail. I was like, how is it possible that he didn't know it was going to fail? And he fundamentally didn't understand that his team was a bunch of new people with little emerge experience. His patient volume is very low. His room is not really well set up for ACLS to begin with. So there's a lot of incoherence between domains. And, you know, I said to him, what you should probably do is just practice the first 3 minutes, but 10 times. And in 30 minutes, I'll guarantee you'll get a better result that's going to last longer. And your first 3 runs are going to take 6 minutes because you're going to say, okay, patient comes in, check a pulse, no pulse, CPR. Well, what's good CPR? Do you guys have a stool? Is there a backboard? Do you get the monitor on? Who's watching the chest compressions? Who's doing quality control? Oh, we don't have anyone. Okay, well, can the Zoll do that? And you're going to mess it up. And then by your 5th time, you're going to be doing it in about 4 minutes. And by your 7th time, you'll be doing it in 3 minutes. And by your 10th time, you'll be doing it in 2 minutes. And that's what you need to do, and practice that as opposed to getting too fancy. And the reason we are like this is because we are all well-intentioned, but when something goes wrong, the harm is to the patient. And I think you'll probably address this in your talk. If you screw up, you're going to die. And that, the motivation is still good, but the speed at which you need to get better starts to change. If I know that I'm going to die tomorrow, I'm going to fix the problem tonight because I got 2 young kids. I don't want to die, right? And I'm going to stay up until the problem is fixed. And so this is something I created just to describe how we fail. And there's a lot of strategy that should go in to how you decide, hey, what do we train, when do we train it, and how do we train it? And I'll talk a little bit more about this during my talk. But there is a place for simulation, but there's a higher place for drilling and strategic training. And this will save you time and make you better.